between over the last 1 decade. 320 patients received azathioprine, 207 being of Crohn's disease and 113 ulcerative colitis. 20.6% developed some form of adverse event. Around 6.5% self-discontinued azathioprine. 17.2% showed irregular compliance to azathioprine, and 10% required some form of surgical intervention. So these 20% who developed azathioprine-related side effects, out of these, 40% could be reinitiated on azathioprine after dose adjustment and temporary withdrawal, and we identified this subgroup of patients as dose-dependent side effects. So, and as we can see here, like 72.7% of the patients who showed irregular compliance had breakthrough symptoms or relapses. And 76.5% of this total cohort was followed up till the point of last, continued azathioprine till the point of last follow-up. Of these, 72.7% attained the primary endpoint of durable clinical remission. And as we can see, more than 50% of these were on a combination therapy of azathioprine and aminosalicylates, and less than 10%, that is just 7.7%, were cases where azathioprine use was mainly as adjuncts to biologics. And despite the use of azathioprine, 6.9% of our study cohort continued to have active disease. I would just like to conclude by saying that our study did have its set of limitations. We assessed for clinical remission, we did not have any hardcore objective parameters of remission, such as the Harvey-Bradshaw index or the clinical Mayo score. The dose adjustment and the dose changes in azathioprine were predominantly done based on physician judgment rather than being directed by thiopurine metabolite testing. But we do have some strengths in our study, that is, there is significant follow-up of patients and there's less attrition, and this is in a real-world scenario outside research settings. And being in a resource-limited setting, we had the advantage to assess the outcomes of exclusive azathioprine use, where azathioprine was used as an adjunct in less than 10% of the patients to biologics. So this is one of the advantages. Thank you.
Thanks, Rohan. So I think that brings us to the very final leg of our session. And just to bear in mind that Dr. Ashwin gave 3 messages or 3 ways in which treatment has changed over the years. And that the first one is the change from step up to top down therapy. How applicable this is, I think each of us will have to determine for ourselves. The second is the use of, is the change from single drugs to combination drugs. And the third was the shift from symptomatic treatment to treat to target. So those were the 3 messages that he gave. And we had these messages from Dr. Devendra Desai as well about the role of proactive and reactive drug monitoring and how it should actually work out in practice. So would you, now, is there anything else? And I think we've already talked about this. Is there anything else that anybody in the audience has any questions, and, or would any of the panelists like to make any final comments?
I just wanted to ask regarding this duration of azathioprine, 8 years. Sometimes I feel uncomfortable when they are in remission. Suppose you've already attained, can we just stop 8 years? Is it okay? Or 5 years? Because we've earlier said that whether you continue or not after 4 years, the relapse rate is going to be the same. Is it still?
So what is the longest that we have a patient on?
8.
So that is 20? More than?
8 years was there?
No. It is more than 8 years was there, but I mean, one of the patients who recently came, he was started when he was very young, but he continues to have active disease. He has Crohn's disease, he's had resection, so he actually now has an ileostomy. And subsequently, we have done a stricture dilatation of the ileum. He continues to have active disease, but he's been on azathioprine for many years. And he has, his whole thing started before biologics, but even now, when we broach the topic of biologics with him, his answer is he cannot afford it.
We have patients who have been on azathioprine for a long time, and they seem to do very well. They get married and then they have uneventful pregnancies. But in azathioprine, sir, what will be the optimal dose? The problem here is I don't think we dose them.
So the thing is, what at least in my practice, what I do is a few things that I follow. One is be cautious about giving or starting azathioprine in somebody who's over 60, because the chance of bone marrow toxicity of leukemogenesis is higher. So it doesn't mean I don't start, but I'm careful when I start. The second thing is I start with a small dose and escalate it. And I also de-escalate azathioprine if they've been quiescent for a long time.
Yeah. That's what we do. We go at about 1.5 milligram per kg body weight, and then probably I have some patients who were 13 years, 14 years when they're Crohn's, now only on azathioprine. They are now 32, but now we have de-escalated and maintained. They seem to be doing well.
Documented remission endoscopically, then I'm more comfortable and I just stop it. Then they're off all the drugs, little worried anytime it can relapse, but we inform them because the disease is like that. You reach endoscopic remission.
No, if you've reached endoscopic and histologic remission, there is no issues. You can stop medicines. And I think the data here shows that we've stopped it in quite a few. See, where was that? Okay. I think Rohan probably has the numbers there, but yeah, durable remission in 14 of these 320 patients. They had histologic remission, which is difficult to define in Crohn's disease, but in ulcerative colitis, it's easy to define.
But I think it's important that we maintain adequate dosage for quite some time before that's important.
Absolutely.
Keep changing it very early, then they go in for remissions.
What is your problem? Why do you stop? Maintain the lowest dose.
So I think Ashwin briefly had a slide on FMT. So do you want to take that question? What is the role of fecal microbiota transplantation in IBD? And it's both ulcerative, again asked by one of our senior surgeons, Professor Shanmugam.
Reach 60 or 65. And the two concerns are the absolute risk of lymphoma is higher, and there's a higher risk of, at least in the US, non-melanoma skin cancer. So there are some people who will absolutely not start it over 65 or stop it. And that's not my personal practice at all, because I've seen some people really do terribly after they stop it. And so as long as they're tolerating it, the absolute increase in risk is still only 1 or 2 or 3 in 10,000. So it's not like all of a sudden the risk is 50%. So I almost never intentionally de-escalate azathioprine. There are people who started it in the 1970s who are still on it, and 1980s, so 30, 40 years. And as long as they're doing fine, I don't see a reason to stop it. Because with regards to FMT, there are, I think, 5 trials in ulcerative colitis, 4 of which have shown a positive benefit to FMT. There are a lot of points of discussion there, I think, with FMT. When patients are asking you about FMT, the number they have in mind is the 95% cure rate for C. diff, which is not the case in ulcerative colitis, right? All the FMT trials, even the ones that were successful, the remission rate is only 25, 30%. So when you tell patients that, they're like, I'm not going to bother with that. It seems like a very intensive thing to have an FMT enema every week for 6 weeks or 6 months for 25% remission rates, which is not any different than with any of the other biologic treatment. With Crohn's disease, there's not even that level of data. But what we're learning is that there are probably a lot of donor characteristics and engraftment characteristics that affect the success of FMT, that with very highly selected